Yes, ma'am.
So, ma'am, it's one. Over to you, ma'am.
Should we start, Khushi?
Yes, ma'am, you can start.
Okay. So, very good evening to all. So, warm welcome to yet another session of FOGSI ICOG Research Methodology and Journal Club. We have again very interesting two presentations, and preceding that, the cherry on the cake is by the talk by Dr. Suvarna. So, next slide, please. So, myself and Charmila are the conveners. Next, please. So, we are extremely grateful to the entire FOGSI team led by Dr. Jaideep Tank and ICOG Chairperson Dr. Parul Kotadwala, Dr. Madhuri Patel, Secretary General FOGSI, Dr. Sheila Mane, she is the ICOG Vice Chairperson 2024, Dr. Sarita Bhalerao, she is the Secretary ICOG, and the entire audience and the faculty, the senior members, colleagues and friends, thank you for joining in today. And we are going to be now for the next 2 hours focusing on various aspects of clinical research as well as the how to publish articles in the JOGI journal. So this is basically a combined effort from the journal as well as the research team. So we are extremely happy and proud to have Dr. Suvarna Khadilkar as the first speaker. She is a professor and head of department and consultant endocrinologist, gynecologist in the Bombay Hospital. So I think the most important thing that we are, I would like to announce today that she has been recently elected as the deputy editor-in-chief of the International Journal of Gynecology and Obstetrics, which is the FIGO journal. So I think that's a huge honor and privilege. Certainly, she's the most hardworking and deserving person to be receiving this accolade, but it makes us immensely proud to be associated with Dr. Suvarna. And of course, we also know that she was the Secretary General elect of FOGSI 2024, President Moggs, Editor Emeritus, Journal of Obs and Gynae of India 2021 onwards, President of Indian Menopausal Society 2017, National Secretary of the Association of Medical Women of India 22-25, President Association of Medical Women of India in Mumbai branch, editors of more than 12 books, more than 100 publications to her credit, and recipient of many national and international awards. So you find that the entire screen is filled with the accolades and the awards. So a very warm welcome to you, Dr. Suvarna, and we are very much eager to listen to you. So I can see Dr. Parul also there. So, so we would like to have a message and a brief introductions. Dr. Parul, please.
Am I audible?
Yeah, we can see you and hear you well.
Okay. Sorry for getting a bit late to Dr. Suvarna's introduction, and each word of that is true. I can vouch for that. Welcome, Dr. Suvarna, and she is going to deal with one of the most important area for our young students and many colleagues also. Mantra for successful publication. We have noticed that so many publications get rejected. Guidance is in order. And then we have two more journal topics. And in fact, both of these topics are really under discussion these days. I've seen the Arrive trial and then subsequently French Arrive trial, and then there are many questions on that. So I'm sure a lot of discussion will happen on that. And the relationship of cesarean delivery and fecundity, that also has been discussed in vogue, a matter of opinions. So both these topics are excellent, and I do salute you, Dr. Radhika, for persevering with these sessions, which now we have made them on alternate month, but they are really looked forward to, and the journal committee as well. So let me not spend more time on all this. Get on with the topics under discussion.
Thank you, Dr. Param. So over to you, Dr. Sumana, please. Madam, you are muted.
Yeah, sorry. I will share my screen soon, but before that, I just want to extend my, express my gratitude, and I thank all of you for saying such nice words. First of all, Radhika, and it's
You
very
deserve it.
humbling, and I really appreciate the amount of work that is going in on the platform of ICOG and JOGI. And I have been witnessing this, and I have been giving this lecture for last several, I think you can say, years, and I thoroughly enjoy every time I give the lecture. I enjoy myself, and it's always good to address to the new upcoming researchers and proposed authors who would like to present their papers. So I'll just share my screen. Can you see my screen?
The screen is visible, but the slides are not visible yet.
Not visible.
Now
yeah.
we can see.
Yeah, ma'am.
Yeah.
Full screen, please. Yeah. Now
Yeah.
it's fine.
Yeah. So once again, good afternoon, everyone. I bring greetings from Mumbai, Bombay Hospital. That's the place where I work. Before I go to the actual topic, I just would like to say a few things about the two very, very high-end journals with whom I'm currently associated. The first, and you can say that is very, very close to my heart, is JOGI, FOGSI. This is the official journal of FOGSI. So it is actually everybody's dream to get Indian data published in this journal. So I have seen it through. I have done this post of editor-in-chief of JOGI for more than 4 years, and it was educative experience for me also. I learned so many things while I was the editor, and that is how I can say what should be done to get your work published successfully in the journal that you want. So the one of the biggest journal on the Indian or subcontinent is JOGI. That is our official journal of FOGSI. And the other journal, which is I've been working on this journal since many years, but currently I've been acknowledged and given this honor of this particular position of Deputy Editor-in-Chief of IJGO, which is the official journal of FIGO. So, these are the very highly, you can say, high impact journals, and they are very, very sought after journals that everybody feels that our paper, our work should be published in these journals on national and international front. So before I actually move to the topic, I would like to say a few things about JOGI, because I have worked on this journal, and this year we have got the impact factor for the first time. And as all of you know, what is impact factor? It is the result of the work done in the earlier before 2 years. So, whatever work and citations that happen, that is given here. And this is about the JOGI, founded in 1950. Founder editor was Dr. Jerusha Girard. And it is indexed now in the various other this thing, but abstracted in PubMed Central, but still we are awaiting the Medline indexing. And if you look at the overview of this journal, we have just received a impact factor that is of 0.7, and that 0.7 is not bad. It's a very good impact factor to begin with. And we have a 5-year impact factor also as 1. We have several downloads, 178,728 in year 2023. And the submission to first decision is a bit longer, that is 25 days. Why I am showing it? Because when you are planning to publish your paper, you should look at these values of the journal, how long it will take once you submit, and what is the importance of the journal, what is the scope of the journal, what is it, other parameters that it is judged with. So these are the things that you should go on the homepage and see the this impact factors and other indices of the journal. So on the platform of FOGSI, JOGI, PICSET workshops have been conducted, and all of you are aware that throughout the year, we several workshops are conducted. We have during AICOG also. So I request all of you to take part in and participate and learn from these workshops. I'm very saddened that the attendance for these workshops at bigger conferences is very very less. So I think more people should attend to avail of the knowledge that goes in with these workshops. So we have done, these are the few glimpses of the workshops. And going to the IJGO, that is our international journal, which is the official journal of FIGO, the citation impact is huge. And you can see here, the citation is 5 point, cite score is 5.8. And the journal citation indicator is 1.07 and impact factor is 2.6. So the usage of this particular journal is shown as the full text. You can see 24,17,319 have been the downloads or full text views, you can see. And usually the speed with which the first decision is made is very small, 7 days, and the acceptance rate is only 27%. Still, I must say 27% is quite high. So your chance of getting the publication done here in IJGO, even though it appears that it is less, but if you look at the acceptance rate, the latest acceptance rate, it is 27%. So and in fact, Indian journal, we have acceptance rate of only 15%. So you can see, see for yourself that which of the best journals which are having higher chances of acceptance. So first you choose your journal, and I just gave you some information on the journal with which I am closely associated. And this was way back in 2018, there was a research methodology workshop which was organized in Dubai at a FIGO regional conference. And I'm very happy and proud that I was a part of faculty then. And I took a click with the then editor-in-chief, Dr. Richard Tanu. Now the current editor-in-chief is Professor Mike Gear, and he's also doing a phenomenal work on the platform of the journal. So let's go to the topic, that is mantra for successful publication. Writing a good quality paper, good quality scientific paper is the key for mantra to successful. If you write a substandard paper, the chance of your paper getting accepted are very poor. But such a paper can be accepted in any other journal which doesn't have good values, good impact factors, or which is not of a particular standard. So don't feel bad that your paper is rejected here, why my paper was not good. First of all, do introspection and ask certain questions to yourself. And remember, there is no way to get experience except through experience. There are no shortcuts. Now, I can tell you that my current appointment is not just happened overnight. I have been working on in the field of editorial positions since 1999. When I was first appointed, you know what my post was? Honorary proofreader. So since then, I've received so many years of experience, and then some progress and some information, some good work you can do on the platform of this. So experience has to go through the proper number of years of experience to have this kind of stature. So introspect, ask yourself, why do I want to write a paper? Is there a compulsion? Is there a necessity? Do I write to just get funds for the publication? I want promotion, so I want to write. I want to apply for a job. Fear of losing a job. What are the reasons that you are planning to write good quality, planning to write a paper? But if these are the reasons, I don't think they are quite right kind of reasons for you to write paper. The paper should be written because of your will, skill, and drill. These are the three components of the art of quality scientific writing, and these are built on the sound foundation of science and integrity. So let me tell you, friends, that if you're writing the paper, you have to have absolutely be honest about whatever your paper is, whatever your results are. You can't manipulate, and have to maintain the integrity, and the integrity of the researcher is very important. And if you are doing very good work with wholehearted honest work that you are doing, then I'm sure the paper's outcome will be very good and it is likely to be accepted. So the value of having your work published. Why do you want to publish your work? Now, it documents that peers believe your research is important. You gain academic credibility. You become known as expert in an area. For example, if I have about 4 to 5 publications in field of endocrinology, people will look at me as an expert in endocrinology, and they will look at me as a so they recognize you. So this recognition of expertise is very important, and usually it comes by having the work published. So you will be asked to be a peer reviewer, because if you are an expert writer, you have worked on that particular subject, you are likely to review another person's paper also, and you will be ahead of the literature, because literature doesn't have something that you have worked on. Yours is a new kind of piece of work that you are presenting to the world. So you are ahead of the literature and very important for academic advancement. I think somebody is disturbing there.
Yeah, everybody can mute, please. Dr. Ravi Kumar, request you to mute yourself, please.
So how do you start writing? So first of all, to choose the research question or form a hypothesis that has not been very commonly discussed or published before. For example, if I already, lots of material is already there on, say, example, anemia. So if that kind of paper is already multiple times has been published, and again you choose anemia on the same type of work, then this hypothesis or this thing which is very, very common may not be, accepted or may not be appreciated. So choose something which is not very common, and there is no point in just confirming the already proven facts, isn't it? So choose a most suitable journal. Choice depends upon nature of the research and the journal's inclination. Okay, so I showed you two important journals with which I closely work. So I know what is important for the journal. So when I receive a paper, I first see whether it is suitable to my journal. So choice depends upon the nature of the research and the journal's inclination. Because if yours is a clinical journal, and if you write too much of say investigations not clinical oriented, something on a basic science, perhaps it will not be accepted easily. So not only the study, the instructions to not only it's important that you study the instruction authors, but most important is after reading and studying the instructions, you have to follow them strictly when you write the paper, because each journal has a different kind of set of instructions. So if your journal is having a particular set of instructions, you follow that for this journal. Suppose it gets rejected and you want to submit to another, you will have to go through the instruction of that journal again and submit the paper. Don't just submit as is. It will be directly rejected because you have not even gone into the details of the basic requirements for the instructions, what are written in the instructions to authors. So analyze various papers which are published in the target journal. Understand the scope of the journal. It is clinical or basic. Based on the objective quality and importance of your study, good impact factor generally indicates quality and importance of the journal. And especially if it is a particularly official journal of any organization, that usually is the most sought after journal. So now if you ask me how do I write, so voracious readers make good writers. So I read all the literature available on the subject which I am focusing on. Reading many well written articles helps you develop an original writing style of your own. Do not copy any writing style. I personally read my own article also again and again. Because writing at one go, it doesn't mean that your article is ready. And even though I have now, say, 30 or 40-year experience, still, even today, when I write, making that draft, making that paper is very, very, there can be still some loopholes. So you read again and again and correct again and again. I give it to my scientific colleagues again to read. So just I tell them just go through it and independently without giving any background and ask them to give some suggestions. So I make corrections suggested by them, submit my article only and only after I'm completely satisfied with the draft of the manuscript that I come up with. So various types of articles, you must understand what the journal has, and you should choose that particular type of journal, that particular type of paper. Because if a particular journal may not have that particular type of paper, and if you want to write for, and there is, I have often seen that if there is a, review article, they write as original paper, and then it creates a very bad impression on editor's mind that if a person doesn't know what type of article you are writing, so they doesn't likely to go in for a further processing. So various types you must understand. There are original articles, case reports, instrumentation and techniques, and short commentary, correspondence or letter to editor, pictorial essay, and systematic review and meta-analysis. These are the common articles that at least our JOGI has, and some more other articles are also there in the other international journals. So first study the type of articles that are that the journal is accepting. Now, how if someone says that crafting a draft is easy, is not doing it right. Let me tell you how much ever expert you are. Of course, there are some examples olden time that you lift up a pen and you start writing, and that's the final draft of a maybe story or maybe any other article. But that doesn't happen always today, because if you want your work to be accepted, just the right way to craft a draft is to first write and then review and revise, review and revise, review and revise, review and revise as many times as required till you are satisfied and your scientific colleague also doesn't have any more comments to make on it. So this is what is important, and this is the way you should write and then submit an article, so the editor will easily or surely will understand that this article, the author has really worked very hard. He has made sure, he has taken care to make each and every correction that would have happened, so that editor with experience, we already know that this is a well written article. So what are the various section headings and their order in the manuscript as it is given here? First is the title, the keywords, the abstract, the introduction, aims and objectives. So if you just take that yellow thing, it is IMRD, which is the standard of the acronym for the section headings. But elaborate ones are given here. Then aims and objectives, material and method, results and observation, discussion, conclusions, and don't forget to add acknowledgements if there are any references, and ethical statement. So the order in which they are written can be variable. Some researchers start writing a section, writing result section first, followed by the discussion and the abstracts. So some others prepare notes while reviewing the literature, and a research question is formulated, which is useful for the useful for writing the discussion section. So the title is written last, as it reflects what the paper is actually about and is most widely read section of the paper. So now let's talk about the title. That will determine whether the paper gets read or no. The title has to be very interesting, has to be catchy. If you write a routine, title which will not incite some interest in the readers, the article will not be read, and it will not be, accepted or even considered for the initial processing. So we'll determine whether the paper gets read or no. Avoid long titles. And of course, some journals may have some limitation to the number of words for the title. Avoid abbreviation and the title format. Remember that this is a scientific periodical and not a commercial magazine. So even though interesting title you want, you should not have something like a movie title or something like a serial titles or something. So like that, so the effects of heat on eyes, heat melts eyes. There are different ways you can write, but choose which sounds most scientific. So what abstract is the most critical part of the paper. It states the main objective sum. And if believe me, if a paper comes to me, first thing I do is read the title and read the abstract. Then I come to know, because how well the abstract is written, of course, it depends on that. It is the essence of the your entire paper. So if your abstract is written well and it exactly conveys what you wanted to say, and if it is of a higher standard, the paper is accepted at least for further processing into the journal system. So critical part of the paper is abstract. State main objective, summarize most important results, and state major conclusions and significance. And as far as possible, avoid acronyms in the abstract, and write and rewrite until flawless. Even for abstract, because some very widely read, section of the paper, and if it is having defects in the formation of the sentences, grammatical mistakes, it is not taken well. Now, introduction section, build case for why study is important, why it is necessary, provide brief background, state hypothesis and central question, and give a one sentence summary of findings. So that is how your introduction will go. Then go to the material and methods. Method should be detailed enough so that it can be reproduced by others, repeated by others, and they can do similar research on in their respective centers. So study period and type of institute must be included, subjects and control of the study, type of the study, ethical committee approval is a must. When I began working for JOGI, the ethical committee approval letter was not compulsory. But, just by merely saying that ethical committee permission was obtained is not enough. Now we need a supporting ethical committee letters, because there have been so many issues if we have not been careful enough to look at the ethical committee approval letter, because then there are some complaints that this is no unethical, this is not approved, because whether it is ethical or no, it is completely decided by the ethical committee, and they give you, so it is not editor's responsibility. Protection of human and animal rights, study design, inclusion, exclusion criteria have to be mentioned, and estimated sample size, power calculation or rationale of the sample is very, very important. Why are you selected this particular sample size, and actual steps of method should be given. Validation of research tool, biases, blinding of observers, done or no. All that has to be mentioned in the material and methods that you follow, and propose primary outcome, propose secondary outcome, and statistical analysis and the tools. Of course, you have to also write about the conflicts and fund supports taken from whichever source. Now, results is again very important. Tables and figures must be straightforward and concise, easy to comprehend, and present main finding referring to the table and figures. Do not speculate or over discuss the results. The results can be compared with the similar papers in the literature under the discussion section, and first answer the question posed in the introduction, that we started looking for. We wanted to look at the various comparison of 2 or 3 methods or 2 or 3 drugs that are used in, for example, preeclampsia. So all this is to be first you have to write that on comparison of 3 methods, we found as per the results that this is a superior method or that is a superior drug. So that first answer the question which you have posed in introduction. Relate your conclusion to existing knowledge and aims and objectives. Do not repeat results, but tabular comparison with the literature reports is fine in the and in fact it is better for the readers so that they get easy comparison with what you have found in your paper and what is there in the literature. So discuss weaknesses and discrepancies also here, that maybe your sample size is poor or your methodology was not there proper, or there was a loophole in selection criteria. So whatever you feel that there are loopholes, you can discuss there. Then you go to the conclusions, the aims and objectives accomplished or no. A clear take-home message should be there, how it will improve the current practice, and recommendations, if any. And of course, don't end the paper unless you talk about future implications. So based on your findings and the literature findings which you have correlated, what is in your way in the future, that you must include in your future implications. Now the references. References are most often, nowadays we have so many apps are there, and so many they change the style of referencing once you feed it in that particular system, and it will adapt to the system of the references that is required by the journal, because you can't give Vancouver type of referencing to another journal which is not accepting Vancouver style. So you have the apps, so already you should put in the references in those apps. So the app does the job of rearranging the references as per the style. So they all should be relevant, they should be recent, be highly selective, and don't just give a wide reference list unnecessarily. Read the references, do not misquote, and use correct style for the journal. Now the overall visual structure of your paper should be really very strong, and you should use sections and subsections, and the bullets, italics, all should be properly done. Find out how to draw pictures and use them wherever necessary. So what are the problems with the peer review? Usually the peer review is slow. It is like, examiner. If you go appear for an exam where the examiner is very lenient, you will get good marks and you will pass. But if it is like a lottery, so if it goes to a stricter peer reviewer, you are likely to be your paper is likely to be rejected. So that is your destiny. That is not in your hand. That is the editor's job to assign a peer reviewer. So if it sometimes the review process that they comments that they put is ineffective, they're biased, they're easily abusive, works for the improving studies, not selecting which to publish, all that. But what is your job as an author? You, in spite of all those issues that are faced not only with the reviewer but also the editors, so you want your work to be published. So be very, very polite, respond to reviewers in very, very careful language, carefully prepare your responses. Each comment should be addressed and each change should be stated, and show some enthusiasm while answering and responding to the reviewers. Because I have seen so many times, after you request for some changes, minor revisions or major revisions, many authors, they get bored. What you need to have is, you have to have a patience in correction and be very, very cool and calm. Don't get angry that what does the peer reviewer think, I am nobody or what, I have done this study and I know what this is. So just be very, very cool, calm. The reviewer may be wrong at times. It's not, because they are also humans. So they may mistake. They may make a mistake. But you be very cool, calm, and show that you have worked on the original draft and made enough changes, and follow each and every revision that they have asked for. Reviewer may be wrong. Be tactful. Thank the reviewer first. That gives a good impression to the editor. Do not respond to reviewers when you are upset, because the first response when you get a rejection is very, very, severe. Like, what does the editor think? I have done so much work. But keep cool. Do not respond unless your cool head is there. Otherwise, you will write anything that is wrong, and then your chance of acceptance is permanently lost. So never call the editor, and talk like this, that I have submitted and how dare you reject my paper. I have received so many calls as an editor. And it's a thankless job, let me tell you, because see, for me, my work is the best. And I don't deny, for me also it is same. I also feel very offended if my work is rejected. But I have learned over the years, because now I am also editor and reviewer, that you have to keep cool and never call the editor to put your influence. Then again, it will go in a negative way. Get help from other authors for answering the revisions. Common problems in Indian submissions. Now, this is something which people will feel. This is the first Indian report of so and so case, but this is the first report as per your knowledge. It is possible that the journal editor and others journal literature will have so many other reports which you are not aware of, and it is like boasting. So be a little polite. We present a very, very rare case. It may be rare for you, but not for the journal, not for the other readership. Plagiarism. If the plagiarism is so rampant today, but now we have a tool which can easily pick out the copied material. So if that is there, it is very, very common for rejecting the paper, and then it can have even a criminal proceedings can be done to depending on what is the degree of plagiarism. Now, introduction, results, and discussions are very repetitive. References are unchecked. The conclusions don't match to the introduction. You started off with a question with something like, which is the best drug for eclampsia? And your conclusion is that our Indian people have mild hypertension. So now there is no connect with your question and the conclusion. So make sure that what you are writing is absolutely sense and it answers your initial question. Now, what do editors want? They want something breakthrough, the wow factor is there. So they want importance. They look at the originality of the paper. They want relevance to the audience, because you may write a very good paper on pathology, but our readers are gynecologists. So we don't want to write a paper in the pathology for a gynec journal. So it has to be relevant to the audience. It has to be true. It has to be clearly written, engagingly written. Means when I start reading a paper, I don't feel like leaving the paper. So if that is the case, the paper will be very well accepted, and the respectful correspondence and publication should be absolutely of high standard. So what are the do's and don'ts of medical writing? Original articles must have originality. Read manuscript is as if it is written by somebody else, and you will quickly understand its true potential. I'm sure, because it is very easy to pick out others' mistakes. So you don't understand, or you can't make out your own mistakes. So always keep the article aside for some time, just freshen your mind and read the manuscript as if it is written by another friend of you, who has written it, and you are here to criticize him. So then you will get the points which will improvise. Poor language skills, take help of language experts and correct the spellings and grammar. Perfection should be done. Ensure that all authors contribute and review manuscript and agree to the whatever changes we are asking. Now, case report submitted purely for its rarity may not be accepted. Just remember, because case reports don't get cited or quoted. So if you submit a case report, it is adding to only number of papers. So the denominator goes on increasing, and your impact factor, that is the numerator, will go on decreasing, because number of papers that are citable, they are other original and all, but case reports do not get cited, or they are citable, but they don't get cited. So it is counted. So submission after complete technical checking is very, very important. Do not submit unless you are completely done the technical checking. Ensure that you respond to all the queries, comply with all the required revisions to satisfaction of reviewer, and do not offend the editor. So this journey of a research article, if my time is up, please tell me, I will skip a few slides. So technical checking, the editor-in-chief first looks at, after technical checking, look at the paper. The editorial discussion happens within 2-3 editors, and they take in, it's like a initial reviewing the paper, and then they decide whether the paper is very bad, then it is rejected. If paper is good, then it is selected and it goes to the expert external peer reviewers. So if good, generally some minor revisions are advised before accepting, and very poor article is rejected, or major revisions are advised. If not up to the mark, they are rejected.
Sorry
So
to interrupt, Dr. Suvarna. Another
yeah,
2
I'll
minutes.
just wind up. I'll just wind up.
Right.
So I will just put, this is the process of research, the decision making, rejection, and I think this one slide I can't skip. These are the reasons for rejection. And this, I have done on, when I was the editor, I completely analyzed my papers. And if you can see the bar diagram, I mean that diagram which is there, pie diagram, which has shown the poor methodology is the highest reason for rejection. Then we have similar papers again and again, no new information is a common cause for rejection. So try to have something new and never done before, so your paper will be accepted. Then case reports not rare, plagiarism, conflict of interest, paper is out of scope. There are so many reasons here, and their distribution, how common they are, is given in this diagram. So these are the rejection rates. I already told you, a good quality research paper will find the space that it deserves in top tier journal. It may be another journal, if not this. Some journals have 80-85% rejection. Some journals have 90-95% rejection. If you see the interesting fact that 62% of papers have been rejected at least once before the other journals have accepted it. So it is an honor to publish your work and review it. The best way to write good papers is to review the work of others. And every one has papers rejected from time to time. Don't feel bad. And rejection says nothing about you. It is only a particular piece of work, and reviewers and editors also make mistakes. So make sure that you don't get offended. So you should write in such a way that you will be remembered forever for your work. Learn the art and craft of making a draft with the skill, will, drill, honesty, integrity, and with dignity. So thank you so much for your patience here.
Thank you very much. I think that was extremely informative and full of wisdom. I would say full of experiential wisdom. I think a lot of us have gained insights into these. With every passing year, I think I myself feel that, you mature in a different way. You understand the nuances of publication. So in your case, madam, you've had so many years of experience and it shows. And thank you so very much for sharing those thoughts of wisdom. Thank you very much.
Thank you. Thank you.
So now we have Charmila to take over. So I find she's now ready in front of the, please,
Yeah.
Charmila.
Thank
So
you so
good
much,
to
Doctor.
connect with so many people. Hi, Charmila, Suchitra.
Hi, ma'am.
Hi,
Hi, ma'am.
hi.
Hi, ma'am.
Thank
Thank you.
Excellent talk.
Bye. Thank you. Thank you.
Thank you, Radhika. Thank you so much, Swarna ma'am, for that very, very informative talk. I think that all the young clinicians and postgraduates who have joined today will have an eye-opener to how to publish in the future. Now we'll go on to the journal club part of the program, and I'm honored to welcome the experts for this program, Dr. Suchitra Pandit, Dr. Poonam Verma. 1 second. Okay, somebody is sharing. Can you go to the experts, please? Yes, Professor Suchitra Pandit is a past president of FOGSI, past president of ISOPAB, has been the chairperson of the AICC RCOG of 2017 to 2020. She's got several accolades to her credit. Madam has got several publications, almost 143 publications. And we wanted Madam to come for this program and give her expert inputs because both are obstetric papers and we wanted inputs from her so that we can go ahead and research in our places also. Next slide, please. The next expert is Professor Manjupuri ma'am, and she's a director, professor, and former HOD, Department of Obstetrics and Gynecology, LHMC in Delhi, has been the chairperson of the Safe Motherhood Committee of AOGD, and she has edited books on anemia, management of high-risk pregnancy, and clinical methods in obstetrics and gynecology. Welcome, Manju ma'am. It's always an honor to have you in any program. The third expert is Professor Poonam Verma. She's from Varda, and she's been a resource person for the Government of India for National Guidelines Development in Maternal Health, Nodal Officer in FDMDR Committee, a member of the Core Committee of MCH Diploma, Indira Gandhi University, has been the contributor to Government of India Toolkit and Clinical Skills Lab Manual. She has given almost 126 guest lectures, and Madam is doing great work in disseminating knowledge regarding the birth skills, and she did a beautiful program for us in Hosur as well as South Con. Welcome, Poonam ma'am. The next expert is Dr. Professor Girija Wagh. She's a vice president of FOGSI for this year. She's a professor and HOD at Bharati Vidyapath Medical College Hospital, Pune, and a senior consultant at Cloud9 and Apollo Hospitals, Pune. Girija has joined. Is she there? I think she joined a little late. I just call her. Thank you so much for joining. The first presenter will be Dr. Sehal Shah. She's a consultant obstetrician and gynecologist fellowship in. Okay. Go back to the previous slide, please. Welcome, Girija. Welcome.
No, don't introduce. I'm here.
Yeah, thank you so much for joining because it's her. She actually forwarded the paper to me for one of our souvenirs, and we found it so good that we thought should take for discussion. And we wanted Girija also there because we know she will give her inputs on such an important topic. Next, please. I will need the presenter CV. Yeah, next. Dr. Sehal Shah, she's a consultant obstetrician and gynecologist, has done a fellowship in infertility, endoscopy, and ultrasound. She's from Mumbai. The next presenter, please. Dr. Shankari, she's a consultant obstetrician and gynecologist, and she has been an assistant professor in the Department of Obstetrics and Gynecology at Dhanalakshmi Srinivasan Medical College and Hospital, Perambalur. A special interest are in adolescent gynecology and high-risk obstetrics. Thank you, Nilima. You can stop sharing. So the first will be the ARRIVE trial. May I request Sehal to share her screen and start the presentation, please.
Good evening. My name is Dr. Sehal. I've done my residency from Pravra Medical College in Loni, and I would just like to say good evening to all of our experts here and everyone who has joined. I will be presenting the ARRIVE trial, which was published in 2018. I'll just share my screen now. Just
Sehal?
Yes, ma'am.
Can you make it a slideshow?
Yes, ma'am. I just need 1 minute. I'm trying to.
Yeah.
Come to the bottom. You have that. Okay.
Go right to the bottom and do a slideshow there here.
Simpler. Sometimes the screen it's not visible, madam. So if they find it difficult to do that. No, you can. Okay. Yeah. It's very clear now. Yes.
Is it visible now?
Yes.
Okay. So I'm going to be presenting the ARRIVE trial, which was a randomized trial of induction of labor versus expectant management carried out on low-risk nulliparous women. This trial, the objective of the ARRIVE trial, the objective of my presentation today is to review the trial's methodology, the results of the trial, and the clinical implications. The perinatal and maternal consequences of induction of labor at 39 weeks among low-risk nulliparous women are uncertain. It is important to understand how the study impacts the decisions of labor induction versus expectant management of labor. The article was first published in the New England Journal of Medicine in August 2018, written by Grobman W.A. et al. Which the purpose of the trial was to compare the outcome of elective induction versus expectant management at 39 weeks of gestation in nulliparous women. The type of study, it was a multi-center randomized controlled trial. The parallel group unmasked randomized trial was conducted at 41 hospitals in USA. The protocol of the trial was approved by the institutional review board in the hospital at each hospital before participant enrollment. Written informed consent was obtained from all the participants, and independent data and safety monitoring committee was monitoring the trial. 50,000 low-risk nulliparous women between 34 to 39 weeks of gestation were screened for eligibility. Eligibility criteria were reliable information of length of gestation available, a live singleton fetus in vertex presentation with no contraindications to vaginal delivery, no planned cesarean delivery, and low-risk nullipara women. Out of the 22,000 women found eligible, 6,000 women provided consent, and they were randomized with 2 labor induction between 39 to 39 plus 4 weeks, and 3,000 women were assigned to the expectant management group. The women in the induction group underwent induction of labor at 39 weeks, but a specific induction protocol was not mandated, and protocol according to each individual hospital was used for induction of labor. The women in the expectant management group were asked to forego normal delivery up to 40 weeks of gestation. They had the delivery initiated before 42 plus 2 weeks of gestation. The outcomes of the study were, they had 2 outcomes that we were studying. Primary outcome was the perinatal death and severe neonatal complications were studied, like a need for intensive care within 72 hours, need for respirator, ABGAR score of less than 3 at 5 minutes, Sorry.
Tech support, please mute those people who are not speakers, please. Continue, Shekhar.
Yeah. So we were studying the 2 outcomes that were studied in the study were primary and secondary outcomes. The primary outcome studied was perinatal deaths and severe neonatal complications like need for ventilator support within 72 hours of birth, hypoxic ischemic encephalopathy, ABGAR score of less than 3, seizures, sepsis, etc. The secondary outcome studied in this trial was cesarean deliveries and other maternal outcomes like operative vaginal deliveries, extension of cesarean section incisions, 3rd, 4th degree perineal tears, indications for cesarean delivery, etc. The results of the study, the primary outcome noted, which is the perinatal death or morbidity, occurred in 4.3% of the population in the induction group and 5.4% of the population in the expectant management group. Secondary outcome, which is the cesarean delivery, occurred in 18.6% of the group, whereas 22.6% in the expectant management group, which was significantly higher than the induction group. The strengths of this study were, it had clear outcomes. This study was a direct comparison of induction of labor versus expectant management as compared to multiple prior studies which have been studying induction of labor versus spontaneous labor. The design was a randomized control trial with a large sample size, allowing to discern differences between smaller subsets which were not studied in prior studies. The eligibility criteria used was very rigid, in which women with only reliable information of length of gestation were included. It also included women with favorable and unfavorable Bishop score in both the randomized groups, allowing us to study the impact of Bishop score as well. Limitations of the study. The results of this study may not apply to high-risk populations or in different subsettings or in different populations, because we only studied low-risk nulli gravida patients in this group. The result focused on short-term outcomes. Long-term outcomes for mother and infants were not assessed in the study. As masking is not feasible, discernment bias was possible, where we had a very selective selection criteria for the population used. The trial was not powered to detect differences in infrequent individual perinatal outcomes. We were only studying more common perinatal outcomes in the study. The cost effectiveness of labor induction in low-risk nullipara women at 39 weeks of gestation was not evaluated in this study and would need to be evaluated to apply the study for future. Implications of the study. While the frequency of incidence of perinatal outcomes in the induction versus expectant management groups was not different, there was no significant difference in the frequency. The relative risk of poorer perinatal outcomes was 20% lower in the induction group as compared to the expectant management group. Frequency of hypertensive disorders of pregnancy was also noticed to be lower in the induction group versus the expectant management group. Multiple observational studies thus far have concluded that the induction of labor is associated with poorer maternal and perinatal outcomes as compared to spontaneous labor. But the findings of this trial are also similar to another study conducted by Walker et al., which compared induction versus expectant management. Significance of the modified Bishop score was also studied in this trial, where women with unfavorable modified Bishop score at the time of randomization at 38 weeks, there was no significant difference noted between both the groups while we were studying the mode of delivery. But in women with a favorable Bishop score, induction of labor resulted in lower cesarean section rates than expectant management. Elective induction of labor at 39 weeks of gestation did not result in a greater frequency of perinatal adverse outcomes as compared to expectant management, and relative risk of those perinatal outcomes was lower in the induction group. The expectant management resulted in higher rates of cesarean delivery as compared to induction of labor at 39 weeks. These results suggest that the policies that are aimed at avoidance of elective induction of labor are unlikely to reduce the rate of cesarean delivery on a population level. This trial provides information that can be incorporated into discussions where we include shared decision making between the hospital and the patient, and we have set up available for induction of labor and management and monitoring. Further analysis and discussion of the data provided by this trial and further research would be useful before substantial practice change can be applied, especially given the difference between a controlled study setting and the generalized practice. Thank you.
Sehal?
Yes, ma'am.
Just two queries which I have.
Yes, ma'am.
Stop sharing. Stop sharing.
Okay.
These are all primies, right?
Yes, ma'am. Primary gravida women, low risk women.
Low risk women.
Yes, ma'am.
Second is there is no mention of, in the expectant management, what is the method of monitoring when you're going beyond 39 to 42 weeks? How were they monitored for the fetal surveillance? Was that mentioned anywhere?
That's not mentioned in the trial, ma'am. They've not specified.
Okay, because then that accounts for, you're looking at the stillbirth rate.
Yes,
4.3 in the first group and 5.4. Where was there a statistical significance in that?
No, ma'am. So that was not just stillbirth rate. That is including all perinatal outcomes, which is including stillbirth as well as other morbidities associated post-delivery.
Correct.
Yes,
but this was of statistical significance, right?
No, ma'am. No statistical significance of the frequency of outcome, but the relative risk observed in the induction group was 20% lower, and they inferred that the absolute risk could be as low as 36% in the induction group versus the expectant management group.
And second thing is, we have not mentioned about the Bishop score. You mentioned it just now, but
Yes.
Because a lot would depend upon the Bishop score, right?
Yes, ma'am. So
especially the maternal outcomes. And
Yes,
the need for a Caesar would depend a lot, because if the
Yes,
Bishop
ma'am.
score is right, I mean it's a good Bishop score,
Yes.
then the chances of a successful delivery or better outcomes are there. So there was no mention about this at all, right?
No, ma'am. There was a mention where they said that women with favorable and unfavorable Bishop score were included in the group, and then they were randomized between the induction group and expectant management group. And they found from the study that the women with an unfavorable score had no difference in perinatal outcomes or cesarean delivery rate, whereas women with a favorable Bishop score had a favorable outcome in the induction group. Women with a favorable Bishop score had lower rates of cesarean delivery as compared to expectant management.
Correct. So that's what, then that comparison has not been done. Meaning they've been randomized, but we don't know exactly how many. Was there an equal randomization? That we don't know.
Yes, ma'am.
Because Bishop score is a very important determinant for successful induction.
Yes, ma'am.
Right? Yeah.
That difference was not mentioned. Whether it was equal number of people in both groups or not was not studied.
Right. And the other thing is, as per the RCOG guidelines for induction of labor, there is a subgroup which now says that, though they talk about induction of labor beyond 40, for the Southeast Asian population, that is, we are included in that, Indians are included in that. because we have other morbid factors, which according to them, they may not be of any value, but they are of value for our group. So in those particular groups, probably a timely induction between 39 and 40 is a better option than waiting beyond 40. So in this particular group, were they all Caucasians or was it a mixed crowd?
No, ma'am, it was a mixed crowd. They studied multiple ethnicities, races, variations were in body mass index, age groups, all of women were included. And they have mentioned that there was no significant difference noted in the outcomes based on these factors.
Correct. So then do you think, if you were managing the trial, what are the changes that you would have made for this? What would be the additions that you would have done for this trial?
Ma'am, maybe we can include a larger group of population and include more centers in the trial so that we can study more varied populations. Because in this population, we were only studying a very low risk group of people, but that might not apply to, especially in developing countries, it might not apply to the majority population.
Correct.
So the implications are not applicable to developing countries as compared to the developed countries where the larger group of people, the maternal morbidities are lower in their population.
So I think we could have a trial of this size in our country.
Yes, ma'am.
That would probably give us the answer to how do we deal with our women.
Yes, ma'am.
Well presented. Thank you.
ma'am.
Thank you.
Manju madam, like your
Yeah.
thoughts.
So, Sahil, well presented.
Thank you.
I think that, in this trial, the recruitment was done from 34 to 38 plus 4, 38 plus 6.
Yes,
So
ma'am.
maybe if recruitment was done at a little later stage, all those hypertensive disorders which came
Yes,
up,
ma'am.
that could have influenced the results as well. Right?
Yes,
So I think if we repeat it, then maybe we can do a recruitment at about maybe 38 weeks or so.
So, ma'am,
Because
they started screening at 34 weeks for the women, but the randomization was done at 38 weeks.
Randomization was done at 38.
38 weeks, yes, ma'am.
All right. But I guess that in this study, there were a lot of, Black women, Afro-Americans. They were more in number. And the incidence of hypertension also, which was reported, was higher in subset. So that means it was not a very, the result which is there does not reflect the actual, the homogeneous population was not there.
Yes.
So that was one of the limitations. And another limitation, which I think is that, the experience, birth experience, that angle is missing.
Yes,
Because when we talk about, induction of labor, then it is always a good idea to include the birth experience, because it's not going to be the same in induced labor versus what it is going to be in spontaneous labor.
Yes, ma'am.
So I think if we do the study, we can include that component, which would have a bearing, right? And then, of course, this kind of study cannot be, if you look at the recent, guidelines on induction of labor, because we are reviewing it for FOGSI, so that is how I know that the recommendation which is given by developed countries are different from what WHO has given. Evidence is good. We do label that the evidence is, reliable because it comes from a multicentric RCT. But when we make a recommendation, that is based on the context, on the equity, on the, the setup we have, right? It cannot be across, we don't have uniform care across all centers. So are we ready to kind of do inductions, so many inductions, and then have the monitoring done? And, would we be able to manage these inductions in such a safe mode? So that is why WHO has given it as a recommendation, a weak recommendation, whereas it is a strong recommendation given by RANZOG. So I think that is something which is important, which we need to understand, that until unless we do this kind of a trial, one, we have to be sure whether it is actually meaningful in our context. Our women are different. And secondly, whether, this recommendation, if we want to make a change in the policy, it has to be equitable. It can't be that, those who can afford can go in for this, those who cannot afford cannot go in for that. So that cannot be a good recommendation. So I don't think so in given context, there is scope for replicating this study here. but not so much of scope of, implementing it across all strata in our country. So that is what is my another point, right?
Yeah.
And when we talk about the cesarean delivery, that's a secondary outcome. So do you think that their numbers were, sufficient, or they had a good sample size to answer the second question? Because normally when we do a sample size, we do it with the primary outcome.
Yes, ma'am. So, ma'am, when they started out the study, the primary aim of the study was to study the primary outcome, which is the perinatal outcomes in this. But they noted then that there was no significant difference in the perinatal outcomes that were occurring, but the frequency of cesarean section rates was then observed to be lower in the induction group. But they didn't start out trying to study, the primary aim was to study the perinatal morbidities only.
So there is a possibility that the study is not powered enough to answer the second question. So that is the importance of reading through the lines and going through the studies deeply and trying to understand as to what is being conveyed. So good presentation and good topic for discussion. So congratulations to the team. Yeah.
Thank you.
Over.
Thank you, ma'am. Poonam, ma'am, your thoughts, please.
So a very good presentation, I would say. Congratulations to you. There were certain things, actually, this particular, article was discussed in our postgraduate activity. So there were certain things which I would like to share. Number one is that, people wanted to be very clear about whether it was 39 completed weeks or it was 39 weeks beginning. So that is one very important thing, because every day you cross, you get more of the oxytocin receptors and your induction becomes much easier. So that was one part which probably is missing because it is not mentioned here. Was it 30? That means if you say 39 weeks beginning or you say 39 completed weeks, there's a difference of 7 days here. That was one. Second was whether I would like to ask you whether the whole study was conducted in the tertiary care hospitals where 24 hours obstetricians were there and the monitoring was there, or it was conducted even in the district hospitals. So I would like to know from you, Sejal.
Ma'am, they've only mentioned that 41 hospitals which were included in the Eunice Kennedy Shriver group, which had a fetal maternal monitoring unit. Those were the hospitals which were included in this.
So I think it was mainly in the tertiary care hospitals. So where, you have 24 hours obstetricians, you have monitoring facility. So will this study be only limited to those medical colleges or the tertiary care hospital? But whenever you are writing such articles and you are making a universal thought, it has to be percolated a little lower level as well, not only limited to tertiary care hospitals. So that was one thought. Then when we say that the secondary outcome was cesarean section, how was it monitored? Like what were the indications? So having said that, the secondary outcome, this one was less, that one was more. So we really need to know how was it monitored? Did we do Robson's classification? How did we look into the indication? And Manjupuri madam has already said, so this part is a little shady. We have to ensure that we have a good record of this thing. So secondary outcomes, although they have seen it, but when we do such kind of a study, we need to look into that part of it. Then considering that, induction involves a lot of cost. So how cost effective it would be always a question for this particular article. And as you all know, your upcoming generation and, the career advancement schemes have come up, and they are really talking about having, the publications of the youngsters, especially assistant going to associate going to professor. You should have high impact journals. So very well presented by Varna ma'am, so you should know which are the journals which have, more of impact factor. They are more well read, and they reach to the community as well, in the sense that, the doctors from PHC, CHC should also understand when you're talking about a low risk case, especially. So those are certain things which we really need to look into. Beyond that, there have been a lot of criticism, because now, as we are talking about midwifery and we are talking about, leaving the labor to the women herself, and, doctors involving themselves only where there are complications. So in low risk cases, why are we doing induction when the women can have expectant management? So calling it as medicalization of labor and all. People have even come up with the terms like obstetric violence and so on and so forth. So whenever we plan this study, certainly this study has to be done, because if the results have been seen, we should do it. And when we are doing it, let us make it multicentric. Let us make it also, at different levels, tertiary care, secondary care, so on. Then we see the results, and then we can go ahead with the. So those were my thoughts.
Thank you so much, Poonam ma'am. Girija, are you there? Girija?
Yes, I'm there.
Yeah. Your thoughts, please.
Yeah, so basically, as Dr. Poonam said, even we had discussed this case in our center. And what I found was, first and foremost, is that this is in 2018, and therefore a lot of water has flown down the bridge. And today, we look at induction of labor in a different way. The gestational age in India of 38 weeks was a question that we raised. What should it really be when we induce this patient? Even if we recruit them at 34 weeks, they would have a change of mind, or they would go in labor. And second thing, what startlingly I felt was, when they have mentioned that this was done in a low risk mother, what was the indication of doing an induction of labor? As Poonam said at the end, we are now looking at, as much as possible, trying to allow women go into natural birthing, as much as possible, to avoid the risks of induction, such as especially postpartum hemorrhage, because now there is loads of evidence which says that induction of labor is identified as a risk of risk factor for postpartum hemorrhage. Are we really right in doing so? Therefore, we, at least in our center, we found that this study got published. It got published in a very reputed journal. They did a multicentric trial. And therefore, if sometimes we are very deterrent, we are very hesitant in our centers to do anything. And we have a lot of robust experience on field. So all of us should come together and try to come up with such kind of trials and studies where we are doing what is, let's say, on a day-to-day basis, what we are doing. So this can be a typical translational study rather than going into, sort of hypothecation or trying to plan a trial. Whatever we are doing, if we are able to collate, I think we'll be able to come up with even better data than what the ARRIVE study came up with.
Yeah.
An excellent presentation, Snehal. Very nice.
Thank you.
Thank you, Girija.
Can I make a point?
Yes, ma'am.
Yes.
I think what is most important in discussing this paper is that seeing the journal and seeing the study design, we all tend to kind of,
get carried away.
Get carried away that 39 is okay. We can start inducing patients at 39. Patients also want an induction, wants to get rid of the pregnancy as early as possible. And we are more than ready. So what is important here is that I think the message which is important is that one needs to look at the internal validity of the study and also the external validity of the study. So internal would mean the limitations which some they have mentioned, some they have missed out. So, that angle also has to be kept in mind. And then you have to interpret it and you have to kind of rationalize it based on your country context. So I think that becomes very important, and that is the importance of having, in vivo studies. Like in your own country, you must have the studies to give these answers.
Madam, that question,
not jump upon interventions.
No, that question I wanted to ask. Are there any Indian studies to say that allowing an Indian mother to go beyond 40 weeks causes problems in the perinatal period?
No, it is.
There are no studies. It is all assumptions. It is all assumptions.
I am not aware of
it. Can I just say something, Sharmila?
Yes,
many years back, Professor Shan Ratnam from Singapore had got a very big database, and these were all Southeast Asian women. I think based at Singapore or Malaysia. And he had mentioned that whenever you're going beyond 40 weeks, the incidence of meconium aspiration and incidence of fetal distress and stillbirths is much more higher. And therefore, for Asian, Southeast Asian babies, look at the other factors before allowing them to wait beyond 40 weeks. So this I distinctly remember. This was when we were actually lecturers. It's almost 20-25 years back data. This is.
Madam, there was an Australian study where they found out that the minority population of Asians had a problem when they crossed 40 weeks.
Yes.
So we don't have any direct studies to say from India that when you cross 40 weeks, the perinatal problem goes up. So that's why I told her to take up this paper, because we need to actually, because all the experts are clear on that. We need an Indian study. We need data from our population to say that if you cross 40 weeks, because I remember that my sister, she's an endocrinologist, and she has done a study on postpartum, that is post-dated placenta. She's an endocrinologist. They've done the placental factors, that is post-dated.
How urine infection is fine?
Girija, please mute yourself.
Sorry.
So what they've said is the post-dated pregnancy definitely has a problem for the baby, in the sense it has got lots of metabolic and endocrinological problems later in an adult life. So that also we have to take into this thing, and we will request Sehal that this should be taken forward, because you've done such a wonderful presentation. Please take it forward. Radhika, we are going to the next paper. That will
Just one addition. Yeah. Can I add one just single point?
Yes, ma'am.
One is that we have to be very sure about the definition of failed induction, which has been a problem and it is a problem. So ACOG says something, this thing. So somewhere we have to have a consensus for India. What do we label as failed induction? Because otherwise your whole study will go away.
Yes,
and second thing is there has to be some funds, we are doing so much. The India has so much of a if you ask, we have so much of data. But, going into the Lancet and going into BMJ, your 1 month salary is expected by them. So how do you expect us to do a very good, journal publication and all? So
Radhika,
these are two very practical aspects which we need to look into for our coming generation.
Radhika is going to help you with your funds.
No, I just wanted to have 2 points to communicate. Number one, we keep talking about primary studies. Now is the time for us to talk about secondary studies. We have enough and more data in our country, please. Let's not even think. We have not conducted a good search. I agree the quality of studies may not be good, but at least let us have all of them in one plate. So please now let us desist from always saying let's have primary studies, because what happens is you conduct a study for 2 years, 3 years, everybody is tired, publication takes another 1 year. By the time it comes out, it's already 4 years. The world has changed. So then we feel that maybe that is now out of context. So I would say time is ripe for us to consider a systematic review. Let us say that these are the gaps in research and this is what is there, and quickly either adopt it or translate that into some kind of a guideline. Our country doesn't have a guideline. Please, we have been struggling hard. We keep on talking of the same things at various conferences. Now we need to go to a higher level beyond these points of discussion. Sorry to be putting it in such raw words, but I thought in the interest of time, I must just put across my point quickly.
Yeah.
Okay. Radhika, you should take this up, for the meta-analysis. You're the perfect person to do that.
I would very much be happy to be doing that. In fact, I would suggest let us have small cohorts of people who can be trained for systematic review. Let us have guideline points and, the identified topics for systematic reviews, and let us conduct good ones for our country. This is what is the need of the time, more than a primary research.
Radhika, I think this can even put in ICMR through ICOG in case you want.
Certainly, we can do that, but we will have a separate discussion on that.
Because the time is running out, we need the next paper.
No, that sounds like a good thing. A lot of people can get involved in that.
Certainly, of course, yes. I totally agree. Yeah.
And a training for the group before they go in for meta-analysis.
Certainly, yes.
Yeah.
So we go on to the next paper, and that is the relationship between cesarean delivery and fecundability, a population-based cohort study. And that is a 2024 article from the American Journal of Obstetrics and Gynecology. May I request Dr. Shankari to start her presentation. presentation, please.
Good evening, respected seniors, esteemed faculties, and the junior colleagues. At the outset, I would like to thank Dr. Chamila Madam for giving me this opportunity. Today, for discussion, we have an article from American Journal of Obstetrics and Gynecology, which is a renowned journal, which has an impact factor of 8.7. The lead time was 87 days, H-index of 263, and SJR is 3.024. And it comes in monthly issues. The editors-in-chief are Catherine Bradley and Roberto Romero. So the article which we have for discussion is the relationship between cesarean delivery and fecundability, a population-based cohort study by Enebeba Tilahun Sima et al. So the study was funded by European Research Council, the Norwegian Research Council Center of Excellence Funding Scheme, and the authors report no conflict of interest. And the ethical committee approval was given by regional committees for medical and health research. The basic terms used in the study are some few things to brush up before going into the study proper. The time to pregnancy, which refers to the duration of attempts a couple is trying to conceive before succeeding. Also, it is a robust marker of women's fecundability. Fecundability is defined as a capacity to establish a clinical pregnancy in a cycle. The likelihood of achieving pregnancy in a menstrual cycle among couples that are engaged in regular intercourse and are not using any contraceptives. Infertility is defined as having tried conceiving for more than 12 months without success. So what is known already regarding the cesarean delivery and the fecundability? Studies done so far have reported that women with cesarean delivery have fewer pregnancies. That is about 10% reduction in the risk of subsequent pregnancies and longer inter-pregnancy interval. Also, cesarean delivery is more common among women with reduced fecundability and infertility. The risk of cesarean delivery is increased, ranging from 1.2 to 2.4 times following with cesarean delivery. However, the most of the studies used inter-pregnancy interval to measure fecundability, which is largely determined by the couple's desire for pregnancy spacing and therefore cannot differentiate between voluntary and involuntary delays in the pregnancy. The medical indications for cesarean delivery, uterine scarring, and placental abnormalities have been proposed as explanations for reduction in fecundability following a cesarean delivery. They also fail to account for potential risk factors such as smoking, contraceptive use, or access to infertility treatment, whereas other studies have very short follow-up. Therefore, the potential role of cesarean delivery on fecundability ratio is unclear. So, why is the need for the study now? Because of the changes in reproductive behavior, use of contraception, delayed childbearing, along with changes in obstetrical practices, that would have contributed to the lower threshold for cesarean delivery in numerous countries. As a consequence, there are more first-time mothers who are exposed to cesarean delivery, making it important to examine the link of cesarean delivery and the fecundability ratio. The potential role of cesarean delivery in reduced fecundability has to be researched. So the objective of the study was mainly to assess the bidirectional relationship between the cesarean delivery and the fecundability, rather than considering cesarean delivery alone accounting for fecundability. The study materials and methods. The study design was a prospective cohort study. The data was obtained from the major Norwegian mother, father, and child cohort study. It is a population-based pregnancy cohort study that was conducted in the Norwegian Institute of Public Health. And it was, in this study, it was recruited throughout 1999 to 2009. The information was obtained from self-reported questionnaire between 15 to 18 weeks. About 95,200 women were included in this study, initial mother study. It comprises all births on mandatory notification using the mother identification, personal identification number. And the medical birth registry of Norway comprises all the live and stillbirths in Norway from 16 weeks of gestation. So in the study, they had two populations. The population 1, where the impact of cesarean delivery on fecundability was studied, and study population 2, where the fecundability's impact on cesarean delivery was studied. Women with at least one recorded pregnancy in the Norwegian trial was included. The MOBA pregnancy is referred to as index pregnancy in this article throughout. To study the association between the first population, that is cesarean delivery in the previous pregnancy, and the fecundability, women who did not complete the recruitment questionnaire and with incomplete TTP data and without registered birth before the index pregnancy were excluded. And also women who conceived with in vitro fertilization in the previous pregnancy were excluded because there might be possibility of pre-existing fertility problems. And for the second association, reverse association between fecundability and the risk of cesarean delivery, when women with history of cesarean delivery in their previous pregnancies were excluded because of likelihood of recurrence. So all the MOVA pregnancies were taken, and the missing questionnaire, missing information, unplanned pregnancies were excluded. And from the information obtained after excluding all these, it was divided into two study populations. The study population 1, as I said earlier, women with no previous pregnancies and previous pregnancy conceived with IVF were excluded. To study the impact on fecundability ratio and risk of infertility. And in the second population, the previous cesarean delivery patients were excluded. And the second study population was used to read the outcome of risk of cesarean delivery. There were many confounding factors and covariates. The study population 1, the proportional probability regression was used, and the study population 2, log binomial regression was used to get rid of these confounding factors. As we see here, there are many confounding factors which could give rise to both cesarean delivery and fecundability in common, and these were eliminated by the binomial regressions. Here we have the table where we assess the impact of cesarean delivery on fecundability ratios. In women with previous cesarean delivery, we had a lower fecundability ratio of 0.9 when compared to the reference of women who had vaginal delivery earlier. This is very significant. Also, when reading about cesarean delivery on the relative risk of infertility, women with cesarean delivery had an infertility risk of adjusted risk of 1.2. When compared to vaginal delivery, it is higher. When reading about the reverse association of fecundability and the risk of cesarean delivery, women who tried to conceive for more than or equal to 12 cycles, there was an increased risk of cesarean delivery when compared with women who are trying to conceive for less than 3 cycles. So the study found a decrease in fecundability ratio following both planned and emergency cesarean delivery, in contrast with other smaller studies which observed a decline among planned cesarean delivery alone. Also, there was increased risk of cesarean delivery among women with infertility. In part, could be attributed to maternal preference, and this was very higher even in especially in women who conceived through IVF. The associations remained after controlling all the common socio-demographic factors and clinical risk factors, and were observed across different parity groups too. Among women with more than one child, those who had a previous cesarean delivery subsequently had a lower fecundability ratio and an increased infertility risk than those who had a vaginal delivery. However, women who needed a longer time to conceive were also more prone to be delivered by cesarean delivery, indicating a bidirectional relationship between cesarean delivery and fecundability. And this could suggest a common underlying explanatory mechanism that the surgical procedure itself may not be or only partly directly influencing the fecundability. So what does this study add to what is already known? We have other studies by A1 longitudinal study by Murphy and colleagues. They also found a correlation between cesarean delivery and infertility in both directions. But however, the study was not able to account for indications of cesarean delivery, intrapartum and postpartum complications. Hence, they were unable to distinguish between indications on the procedure itself. So previous studies have linked cesarean deliveries with subsequent reduced fecundability, but this could be because of common underlying mechanisms rather than the procedure itself. There were some strengths of the study, like there was a large sample size from the prospective population-based pregnancy cohort. Comprehensive information was obtained on both exposure and the outcome, thereby minimizing the recall bias. The use of linked data allowed for the investigation of a bidirectional relationship between the cesarean delivery and fecundability, since the basic cohort was from the single population. But the study had certain limitations, like it included only women who successfully conceived after the cesarean delivery. The study did not include people or the couple who did not conceive or who experienced pregnancy losses before 15 to 18 weeks following their first cesarean delivery. So this could lead to the bias estimates towards the null. And also it lacked data on non-IVF treatment facilities like ovulation induction and intrauterine insemination and the indications for cesarean delivery. In contrast with high-income countries, the Nordic countries generally have a lower cesarean rates. So this could not be correlated with the higher cesarean rate countries. And to conclude, the occurrence of uterine scarring owing to previous cesarean delivery has been linked to adverse pregnancy outcomes such as ectopic pregnancy and abnormal placentation. Similar mechanisms have been proposed to explain the difficulty to conceiving after the cesarean delivery. Bidirectional relationship between cesarean delivery and fecundability is established, and this could be because of the common underlying explanatory mechanisms than the surgical procedure itself. And also the study throws some light into future scope, like future results examining the relationship between cesarean delivery and subsequent early pregnancy losses would be valuable because that could also lead to reduced fecundability. Also, future studies that assess the role of maternal anxiety on fecundability and interventions during childbirth are needed because the maternal request, cesarean delivery on maternal request has been on rise, and the impact of that has to be studied. Thank you.
Wonderfully done, Shankari. May I request Suchitra madam to give her thoughts? You can stop sharing.
Okay.
First of all, Dr. Shankari, nice meeting you again. You presented very well, but just one advice: when you're presenting data like that, always your font should be, black color so that it's more visible.
Okay.
Otherwise, it gets very dull.
Okay.
Second is,
Madam, she has not stopped sharing. You have to stop
One
sharing.
minute,
okay.
You just diminished it. Okay. Yeah, fine.
Yeah, so that is about just the presentation is excellent, but should be a little more bold font.
Okay.
And I understand that the study was done with the bidirectional study with between cesarean section and fecundability and vice versa. But I fully agree with the limitations because they have included only a specific group that have conceived, and I fully agree that unless you find out what are the early pregnancy losses, that there will be a lot of element of bias because only you're looking at successful pregnancy outcomes as in a delivery. You're not looking at ectopic or miscarriage risks that are occurring. So that is something which is completely lacking. So we cannot then give a blanket statement. And second, I think I tend to agree with the fact that post Caesar women are very scared to conceive for by on their own. They would like to defer for at least 1 to 2 years. We also advise wait for 2 years, but that maternal anxiety levels are very high, and sometimes by chance they conceive because probably there's lack of protection or the whatever the reasons may be. They're not doing it out of choice. I don't think any women wants that. So that factor, had they given a little more importance, maternal choice and maternal anxiety. It's also a question of maternal choice. That would also determine the impact on the fecundity. Because I feel if a woman is counseled properly and given appropriate contraception, she probably would not opt for a conception one or one if she's in the right age group. She would wait for at least 1.5 years, 2 years till the child is grown up. So that is something which is totally missing in this particular study. But I think they have got that correlations. The sample size is very big. In fact, I'm surprised. Norway is a country. All the Scandinavian countries have got excellent databases, so they're able to pick up all the results. And the third thing which I wanted to say, when they're saying that there is an increase in cesarean section rate after IVF, yes, but after infertility, even IUI, that is not very clear. Was that very clear?
No, ma'am. That was the limitation of the study.
Yeah. So that is something, because after IUI, normally you would even consider a trial, and every IVF need not be sectioned. But I can understand the general trends is, the more if the patient has had an IVF, a complicated IVF, chances of a seizure are higher. But for an IUI, that is a data which I would say is missing. But otherwise, your style of presentation is excellent. You're very confident of what you are presenting. Very good.
Manju madam?
Yeah. So well presented, Shankari. And I found the methodology pretty complex and not very clear, but you have kind of put it correctly. So I just want to understand, when they said it is a prospective cohort study, does it mean that they started following the cohort from 1999, or they just went back and looked up the records?
No, ma'am. They went back and took the records, and from the collected data, they started to analyze towards the outcome.
Agreed. So
Okay.
that means they were not clear about what was their question when the patient started getting recruited.
Yes, ma'am.
So did their questionnaire include whether it was voluntarily, how long did they not want to have a pregnancy?
The cohort was actually recruited for some other study. They took the database from that study and they started reading the outcome.
No, I agree to that. But did they clarify that did they have that part incorporated in their, in their performer, that how long did the patient, abstain for becoming, how long did the patient avoid a pregnancy voluntarily?
Yes, ma'am.
And when did they start,
Yes, ma'am. Actually,
trying?
that was the strength of the study, ma'am. Because earlier studies they took only the inter-pregnancy intervals. They
So
didn't
here they had clear data on that.
Yes, ma'am. Because in this study, they specifically asked for how many number of cycles the couples were actually trying for conception.
So they had gotten
They
that.
had asked this.
And then in the confounders, did they use, was the use of contraception kept as a confounder?
Yes, ma'am.
When they did that, regression,
Yes,
logistic,
that was
regression
the
analysis.
These things were the actually differentiating point from the earlier studies and this study.
So that was another strength that they kept that also in mind. And again, my concern here is that they have taken patients who conceived with IVF. So I don't know. I'm to say in Indian context,
They have excluded people who have conceived with IVF, ma'am.
No,
But they have
in the previous pregnancies, not in the index. In the index, they had included patients who had conceived with IVF. I think that could have also been a confounder.
Yes.
No?
Yes.
Yeah. And I think we do, and it is not that they have taken, they have excluded high-risk pregnancies or anything. That is not
No,
here.
they have not excluded.
It is not that it is a uniform population which they are looking at. So it is a very heterogeneous group. So I think that makes it clear that we have nicely discussed two studies, one with a very good design and one here we know that the level of evidence is poorer because there are so many biases. So, it is not a kind of a pre-designed study kind of a thing. But I think a good cohort study in which they have tried to put in or take care of the limitations which were there. But of course, the conclusions which they have drawn may not be correct. So I think, again, a role of having a prospective study. So wherein you have patients recruited who have previous cesarean and those who have not had previous cesarean, and you follow them through, right? Have a performer. So it will take time. There is no doubt about it. But I think that is going to give you a sure, short answer. That is one. And second is patients who already have difficulty in conceiving, right? So we follow them up and see how many of them have cesarean. So two parallel, prospective studies might give a robust answer to this question, although it will be time taken. We can't rely on this, I'm to say. This evidence is not worth depending upon and making a recommendation based on that. Yeah. Thank you so much. Shankri, I appreciated the way you had simplified the whole data and presented it. I quite enjoyed it. Thank you. And the person who selected the articles also need to be congratulated.
We actually grilled her on that presentation.
Yeah, very nice. Very nice. Yeah.
Myself and Jayam madam, we're looking through the slides again.
Yeah, good.
Poonam madam?
Yeah, Chandila, really wonderfully presented by her and very nice articles to be discussed on. Now, most of the things I think both the experts have spoken about. This particular article is nothing new because there was a very interesting article of impact of cesarean section on subsequent fertility. This was a systematic review and meta-analysis by Gurol and Arganci, which was published in Human Reproduction. I think it was 2013 when they had discussed and they had come out with the similar results that many studies have correlated that your fecundability, your infertility profile, all that increases with the cesarean section. So these results are also promising. Already mentioned There is slight variation in the designing, which I personally feel, and also there are some residual biases which are there in the study. But overall results are pretty good, and the way she has presented made it very simple, so you can compare. That way it is good. But certainly we need to look into it with our perspective. How do we have in our country things? Because cesarean section being done in developed countries, cesarean section being done in our country, the asepsis and so on and so forth. So we certainly believe that it is surgical procedure which is also responsible. But as this particular study very categorically say that it's not only surgery, there are a number of things, we completely agree with that. So thank you very much for
Thank you, Poonam ma'am. Girija?
Yeah, as I would agree to what Puri madam said, this is a very, very complex study, I felt. The study design. And we can emulate a similar study in our setting, but I must congratulate Shankari for a wonderful presentation and trying to make it as simple as we can understand. But I think we would want to design this in our own setup. It would be a great idea to see actually define correctly, because that definition of fecundity, what we mean, is an extremely important thing. And what was it in this study? If you can tell us, how did they define fecundity in this study, Shankari?
Ma'am?
Do you know what was the definition of fecundity in this study?
The number of cycles the couples are actually trying to conceive without any use of, contraceptions.
Was how they had defined it.
Yes, ma'am. The number of cycles.
Number of cycles.
Cycles, ma'am.
TTP.
So,
TTP.
May I add a comment, Charmila?
Yes, Radhika.
Yeah. So we all agreed complex study and difficult and all that. And whether it has got translational value and does it have an external validity. The point is now time to focus on our country. We have all been doing that all throughout this program. Now we need to have our eyes open to this fact that the medical services in our country is now of two types. You have the practitioner, the private setup where things are available. Everything is now there. So we can't go on. For how long are we going to say that this is not applicable for our country? So now we need to have, probably it will be one of its kind, to have a guideline which addresses the practices for a setup where everything is available, vis-a-vis a setup where things are not available, number one. And for that to function, we need to have the public-private partnership. So what is happening all this while is, while the ministry is trying to get everybody under one umbrella, it's just not happening. And therefore, our practices are not standardized and they are not auditable. We really don't know what is happening. Every time we meet and we say nothing is available, we don't have evidence. And that is because we are not working as a cohesive group, and for which FOGSI has a major role to play. I don't think the major office bearers are here, but we take ourselves.
We are major for office bearers this year, Girija and myself.
Oh, great. I am so happy. Please address this issue, because every time we sit in any forum, we keep saying that we are a poor country. And in the World Bank category, we no longer are, the poor countries. We do not get any waivers for our publication. We suddenly become higher income countries. And Pakistan, Sri Lanka, everybody gets a waiver. And we are suddenly at the higher level. And then when it comes to health services, we say it is not applicable. So there is a huge gap between the public sector and the private sector. The guidelines and the practice points for the two would be probably different. And we need to address all our, if we plan our guidelines, it should be for the primary, secondary, and the tertiary level. And tertiary level in the public sector might be very different from what it is in the private. And we need to have a cohesion between the two to be able to have some sort of clarity in the way we are working. So there is a lot of confusion that we are going through.
Radhika, if I may
Yes, ma'am.
participate in this, I feel that some kind of a registry can be started. because cesarean section is such a huge issue which needs to be addressed, and whether it is a consequence of decreased fecundity, or it is a kind of cause for decreased fecundity. One needs to look at that and start looking. ICOG and FOGSI can kind of look at and collect our own data, because
I totally agree with you, Dr. Manju. In fact, in the past 5 days in various meetings, we have been able to identify at least 6 topics to develop a registry for. So it could include centromin, postpartum IUCDs, it could be cesarean sections, so it could even be the STI, the syndromic approach. So there is a world of, there is a gamut of things that we can work on. But yes, we need to move forward. We need to have a system in place. So since we do not have that, and we are, working in silos, not exchanging ideas and, that kind of a thing. So now is the time for us to change, and somehow, these are times we go on reiterating and exchanging ideas. And a few months from today, I'm sure we will all get together and have a better. So registry, I totally agree with you. We need it. There are major topics for our country, including genital tuberculosis. So many, the eclampsia, pre-eclampsia. So anemia is another one. So these are so many topics, and we have such a lot of work to be done for our country, and it's high time we take off.
So the research club is bringing out some ideas, at least to start somewhere.
Yes.
Yes.
Can I add something, Dr. Radhika?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Please.
There are few things which I would say. Most of the research data which comes generally and we publish comes from the tertiary care hospitals when the postgraduates are doing their thesis, and then you take out the articles. Now it is very important to assess that the postgraduates who have done the thesis or the 3 years data, somebody should have that accountability, that how it has been conducted, and the biomedical research and the research committees of the medical colleges can be involved in, looking into the authenticity, looking into the way samples have been selected, and what has been the sample size and all that stuff. So to make it more robust, I would say ICOG, the medical colleges people, the private setups where, you have big corporate hospitals, they are doing such big job. Sometimes, all of these have to come together to have real data of all varieties, whether it is public hospital, private hospital, and so on. Probably that would also make a difference.
So may I give a quick response to that comment, please? So we had
Radhika, after you, Parag will need to talk because he's
it's a very quick one. So we had published an article regarding what Poonam is saying just now. So we actually, the systematic review will sort out most of the questions that you asked. We don't need a separate body to do critical appraisal of what has been published. That will be automatically done in a systematic review, number one. Number two, in our a quality appraisal of the studies that were published in India. So there was a huge change between 2015 before and 2015 afterwards. So the inclusivity increased. It was initially taken, as the tertiary centers and the medical colleges as the premier institutes. It's no longer the case. The corporate hospitals are coming out with very good data. They are also publishing. So if you were to again undertake a systematic review, everything will come in one basket, and that will prove the point. So again, so my humble point is to have a systematic review.
I fully agree with it.
Yes.
Parag, your.
Yeah. Okay. Radhika, just to want to let you know that it was almost 10 years ago when Dr. Suchitra Pandit was the president of FOGSI. At that time, Suchitra and I had an opportunity to, review or formulate the GCPR on cesarean section, and it is still there on the ICOG website. So, when we were formulating those GCPRs, we, broke our heads so many times that we wanted to be inclusive. We didn't want the GCPR specific only to the tertiary care hospitals or, big hospitals in metro. So we've in fact tried our best to put in everything. so that whatever minimum standards of care they are followed, rather than being very specific about, say, suture materials or even closure techniques. Suchitra, your comments, please.
Yeah, I know. I fully agree. And we had so many discussions over, a low tire, a third tire, a high tire, a corporate should be different. And everybody, the consensus was no, have this as a minimal standard of care. If you can do better than this, great. But kam se kam itna to should be there. And I think that's what we had tried to give in that particular GCR. Fully agree. And so, we can't separate it out again. Very true.
And actually appeal to Radhika, please train us on systematic reviews.
Yeah, I would be most happy to do that. And
once you send us the thing, we'll all join. We'll all join.
Happy to learn from you.
We would like to join, although we know a little bit, but certainly we would like to attend that training.
So you take us as the first cohort. We are all ready.
And Radhika, what I feel is, I think even Parag is there. So we keep making GCPRs and all, but most of the people are not trained in making recommendations. So doing meta-analysis, this is capacity building. Making recommendations, I think all that is a huge task. It is not, it has to be a gradual exercise. How do you assess the quality of articles and all that? And only then you move on to, making evidence tables and go on to making recommendations. So I think somewhere it is more of subjective things which we kind of put out because we are not trained. So ICOG should definitely look at core training of as many number of people as possible.
ICOG chair elect is there. We'll put up the proposal to him.
Yeah,
I had actually
Radhika and
put up this
Charmila both are
proposal.
my governing council members next year. So
Wonderful.
they have to start, and even Shobha. So three of you will have to start working now, and maybe in a month's time we'll have a quick meeting and then we'll take it ahead.
I can voluntarily help out.
Can I say
Manju, you have
Very nice.
choice.
It's like music to my ears. I've been trying to do this since the past almost 3 years.
You didn't offer to train us. You didn't offer to. This is the first time I'm hearing the training.
Train with the, I think this cohort should start. Yeah,
I had in fact formed a module and sent it to FOGSI that I wish to undertake a training program.
Yeah,
yes,
but
probably I can speak to the right people.
Send it to ICOG.
Today God has given me the right platform.
FOGSI is hands full. Send it to ICOG.
Shobha madam wants to say something and we'll finish with that.
Can I say something, Charmila?
Yes, ma'am. We'll finish with you because the time is going to, it's a 6 o'clock.
Yeah.
Madam, it's yours will be the last this thing.
Yeah. So I just wanted to tell my good friend Radhika that your time has finally come. So you have approached the right team this time. On a more serious note to Shankari, very important that postpartum women, there is absolutely no mention about the reproductive intent. They should have actually started with that. What was the reproductive intent of the women? Contraception is good, but there are so many women who want contraception and don't get it. So that's an unmet need, right? That is an unmet need. And without kind of exploring which patient has unmet need and who does not, because obviously in your study, they have combined the two, those who had unmet need and who did not. So that is the main difference. So reproductive intent should have been outlined first. That is the one point I want to make. The second thing is retrospective studies in today's world have very little weightage and meaning. They are very, they don't augur well because the data collection is always kind of not very credible, and only prospective trials will make any sense. Being country specific, I would slightly disagree with Radhika that there will be a dichotomy in private and public sector. I feel the whole problem is that there is a dichotomy. So we need to have uniform standards in postpartum care, especially contraception. And very, very, very sad to see many women with unintended pregnancies 6 months after cesarean section. because the primary surgeon did not offer contraception. Okay, so there is a huge unmet need for postpartum women with cesarean section. They are the ones who should not have an unwanted pregnancy, very, very specifically, and they are not given that care. So in our country, the scenario is very different. In the public sector, at least there is PPIUCD, at least there is Antara, and now there is implant, so women are better protected, actually speaking.
Madam,
It is in the
we'll
private
have
sector
we
where
will
there is
have
a
this
lacuna.
thing on contraception soon. We'll have
Correct.
a journal
Yeah,
club on
yeah.
contraception.
Sorry. I did not want to go off into that. The third thing which I wanted to tell you, Shankari, is whenever we do a presentation, especially in a journal club, make it a point to bring in some of the cross references which you have identified in terms of what are the other parallel studies which you came across, especially if there is anything related to LMIC. Okay, the low and middle resource income, because that will be mirroring our situation a little bit more. Because I must tell you that where we lack in research, you must look at countries like the African, the Vietnamese, and even I think Kenya. There is a lot of work in postpartum care. There's a huge amount of work in postpartum care. So one should try and get data and then compare as to how that was and how this was. Not for this particular study, but going forward. But then I congratulate you, because I feel that your generation, if you come forward and look into what research is going on, that speaks very good for the obstetricians of India, because I think more and more young minds should work like you and should be very analytical. It may not translate into this specific care, but it definitely translates into more thinking minds while you treat your patients. So I think that was a very good effort. And I congratulate Charmila and everyone who have organized this. And I'm happy for the time given to me. Thank you, Charmila.
Yeah. Thank you, ma'am. So we'll finish the Journal Club and Research Methodology program for today. I'm extremely thankful to Dr. Swarna Kadilkar for that beautiful talk. I'd like to thank all the esteemed experts. You added flavor to the program. Otherwise, it wouldn't have been a success. It gets recorded and people see it more often in the website when it happens. Thank you, Professor Suchitra, madam, Professor Manjupuri, ma'am, Professor Girija Wagh, and Professor Poonam, ma'am. Thank you so much for your spending your valuable time, because this gives so much of credibility to us, because when we have experts like you talking in a journal club, it adds always merit to the program. Thank you so much for all you've done. Thank you, Parag, for joining us and giving your inputs. Thank you, Shankari, as well as Shekhar. Beautiful presentations by both of you. And thank you, Girija, for those articles. Thank you. She shared with me all the articles. Thank you so much. Thank you, Shobha, ma'am. You joined us.
Thank you.
Thank you.
Thank you. Everything and anything for you, Shami.
Thank you, Girija.
Thank you.
Thank you, Radhika. Thank you so much. We'll meet next month again. Yeah. And for the cohort, we are ready with the cohort. Please be ready.
Thank you so much all. So far away, I'm ending this session. Thank you.